Hello, and welcome to Mount Sinai's webinar, Back to School, the COVID-19 Context for Children and Adolescents. On behalf of the Mount Sinai Kravis Children's Hospital and the Mendich Child Health and Development Institute, thank you all for joining us. My name is Dr. Kecia Carroll, and I'm the Chief of the Division of General Pediatrics. And I am a professor of medicine and environmental medicine and public health. And I am going to be your moderator for this webinar. So over a year ago, Mount Sinai was the epicenter of the COVID-19 crisis. Our frontline healthcare workers, Gelb for children and adults battling COVID-19, our brilliant scientists defined the way we treat children with COVID-19 and MIS-C. Our heroic frontline pediatric teams answered the call to action to care for our most vulnerable patients during the height of the pandemic. And our social workers provided essential support to address the psychosocial toll of the pandemic on our youngest patients. Today, it is my honor to welcome my colleagues, Drs. Bruce Gelb, Shanna Kowalsky, and Kristin Oliver, to join me in discussing the SARS CoV-2 vaccines for children, the Delta variant, and vaccine boosters. We look forward to answering your questions at the end of the panel discussion. Before we begin, let me introduce the panelists. Dr. Bruce Gelb is the Gogol Family Chair and Director of the Mendich Child and Health and Development Institute, and professor in pediatrics and genetics and genomic sciences. Dr. Shanna Kowalsky is an assistant professor of pediatric infectious disease and the pediatric associate hospital epidemiologist. And Dr. Kristin Oliver is an assistant professor of pediatrics, environmental medicine, and public health. Thank you, Drs. Gelb, Kowalsky, and Oliver for joining us today. Now let's get started. So Dr. Kowalsky, can you comment on your experience with COVID-19 in children since the onset of the pandemic and discuss how treatment for kids has evolved during this period?
Sure. So I think the silver lining of this pandemic is that children in general have fared far better than their adult counterparts throughout this pandemic. And while most respiratory viruses we sort of think of as diseases of childhood where, young children are the common spreaders, it seems that for the SARS CoV-2 virus, it's been behaving a little bit differently thus far. In the US, as of now, there's about 4.5 million children that have tested positive for COVID-19 since the onset of the pandemic. And right now, children represent about 15% of the total accumulated cases that we're seeing. And we have seen a little bit of an increase over the past few weeks in child cases. And likely we're seeing more children infected now rather than earlier in the pandemic, just because we have more adults that are vaccinated and we still have young children that are waiting their opportunity to get vaccinated. Fortunately, at this time, the SARS CoV-2 virus and COVID-19 illness really has been more of a mild illness for children, and really, severe illness, hospitalization, and death is really a very rare event. About anywhere from up to 0.03% of all childhood COVID-19 cases resulted in death. So really very rare. As a medical community over the past year and a half, we've learned a lot about the SARS CoV-2 virus, how to diagnose it, how to treat it. Fortunately, the majority of children will have mild symptoms. They'll be able to be managed at home, similar to many other respiratory viruses. For those that have more moderate symptoms or more severe illness that do require hospitalization, we do have, supportive therapy for them. We do have the ability to give them supplemental oxygen as needed. We have an antiviral medication that has FDA approval for children over 12. And it's given an emergency use authorization for those under 12. We have steroids. So we do have some medications that we can offer if it does get to the point where a child is kind of on the sicker end and needs hospitalization. We also have some medications like a monoclonal antibody, which is an antibody that can neutralize the virus, which has an emergency use authorization for kids over 12 who are at more risk, who have underlying medical conditions that place them at more of a risk for severe illness and more risk for disease progression. And in those cases, if they have mild illness, they can actually get treated before they get sick. And actually that medication has recently been also granted emergency use authorization for what we call post-exposure prophylaxis. So those high-risk kids who may have had a high-risk contact with COVID-19 can actually get the medication before they get sick. So we do have some things to offer, if kids do in fact get sick or they're more at risk of getting severe disease. Many of you also have heard of the MISC, or the multi-system inflammatory syndrome in children. We started seeing cases at Mount Sinai at the end of April into May of 2020. That's where children that have had an acute SARS CoV-2 infection, probably in about the prior 4 to 6 weeks, oftentimes undiagnosed, presents with signs of overwhelming inflammation, which is probably like a dysregulated immune response to the virus. And we've also refined our treatment for that condition over the past year and have different therapies that we can offer the children. So again, the majority of kids are just going to have mild illness, will be able to be managed at home. But we have learned a lot over the past year and a half and are ready and able to treat the children if they do require a more escalated level of treatment.
Thank you. Now, Dr. Oliver, what do we know about the vaccine trials for children under the age of 12 and when the vaccine will be available for this group?
Yeah, I mean, not soon enough, right? Is the easy answer. I think we're all really waiting for those vaccines to get approved in this group. Right now, where we're at, right? Pfizer has an EUA for the 12 to 17-year-olds. Moderna has applied for an EUA, and I think that should be imminent. So soon we'll have another vaccine available for that age group. And then they're both in trials for anybody under age 12. The next group that we're going to see data for, and then an EUA for, is going to be the 5 to 12-year-olds. Pfizer has said that they expect those results sometime in the fall, and then the FDA has to, review and approve them. So I think no one knows for sure. I've been telling myself and other people who ask, sort of January 2022 seems realistic. That way, I'm not going to disappoint myself or others, and hopefully, it might be a little sooner than that. But I think we'll see. Unfortunately, I wish I could tell everybody it was sooner and it would be in time for back to school. And then also recently, Moderna said that they're going to basically double the number of participants in their pediatric trials. And so they're going to go up to 13,000 participants. So I expect, they haven't actually said that's going to change their timeline, but you would expect it's going to change their timeline a little bit, especially as we get below age 5. So it could take a little bit longer for that age group. Again, they want to do that to make sure that they're going to have a greater chance of finding some rare side effect associated with the vaccine in this age group.
Thank you. Dr. Gelb, aside from the vaccine clinical trials, what research is ongoing to understand the effects of SARS CoV-2 in children?
First, thank you to everybody who joined us. Sorry, I was on mute. How many times have we made that mistake over the last year and a half? So in terms of thinking about the research piece, the first thing I point out to people is, we're still studying the 1918 flu pandemic. It's been a little over 100 years. So be a little patient. It's going to take some time to work things out. Aside from the trials for kids, the initial focus for sure has been on MIS-C. So we did some important research here at Sinai. We started collecting samples from children to try and understand why it was that a small fraction of individuals who were young, who got exposed to the virus, developed this overwhelming systemic reaction that Shanna mentioned. Those studies are ongoing at Mount Sinai and many places. And what has really happened now is that a number of studies have formed up where institutions are sharing data, sharing samples with one another in order to get to a bigger picture, because most institutions have some, but not enormous numbers. And the more you have, the more you can learn. In the meantime, the federal government has instructed NIH to allocate a large amount of resources behind studying that. And much of that, of course, will go towards studying the adult disease because that's been most of the epidemic. But they also are clear that they'll be studying the effects on children of various ages. And we're certainly participating in that, and we hope to understand it. One area that I think hopefully will come out of this, it will be applicable for children, but for adults too, is the so-called long haul effects. And most people, I think, will know that long haul effects are not new to COVID. I mean, people have known, for instance, after exposure to that virus, some small percentage of teenagers will struggle for quite some period of time with fatigue and other things. This has been a mystery in medicine for a long time. And because it's unfortunately happening at scale now in response to this virus, this coronavirus, we really have an opportunity to learn more about that. And I suspect if we do get to the bottom of that, the lessons will be applicable to other types of infections as well. So that would be quite exciting.
Great. That's great information. Dr. Kowalsky, with the Delta variant now a major player on the scene, how will this impact our children as they head back to school in the upcoming weeks?
Thank you. So I'll just talk a little bit about variants in general. So it's normal for viruses to change, or what we call mutate over time. It's sort of like a game of telephone. If you have a group of 10 people sitting around in a circle, especially like children, and you pass on the message to one person, by the time it gets to the last person, the message is nowhere where it started, to begin with. So you could think of the virus sort of like that. And over time it changes. And so, we've had several what we call variants throughout this pandemic. Originally, a lot of the variants were given the name from the country of origin. So we had like the UK variant, the South African variant. And then it was sort of decided that probably naming the variant by country is not the best idea, and maybe people were blaming other people. So it really just goes to show you that this really is a global pandemic. There's many, countries, almost all the countries throughout, the world that are involved. So then they switched to talking about the variants in Greek letters. So now we have the Delta. So here we are with this new Delta variant. So the Delta variant, though, it did originate out of India, sort of in late 2020, and then we saw maybe like sporadic cases here or there in the US kind of in late spring, but now it's the predominant strain that we're seeing here in the United States, definitely in our geographic region, and it's been sort of predominating now since July. So the thing that's kind of more notable about the Delta variant versus the one we were seeing before, the Alpha, is that it seems to be more infectious and more transmissible, probably twice as much so, whereas the previous variant, for let's say every one person that had the SARS CoV-2 virus would infect like 2 other people. Now for every one person that has it, they can infect like 5 other people. So I think that's where a lot of the concern is rising. Also, thinking about waning immunity to the vaccinations, especially people that got vaccinated earlier on in the pandemic, around like December or January. And what's a little bit different also is that the previous variants, it seemed like the vaccines were holding up a little bit better in terms of like infection at all, even asymptomatic infection. So the vaccines will protect you with this variant against severe illness, against hospitalization, but probably allows for a little bit more of that asymptomatic or more mild infection, which is why it's really important and why we're sort of back to masking in the indoor setting, even for vaccinated individuals, after our 6 weeks of honeymoon period that we had that was really enjoyable kind of over the summer. So I think now, in thinking about how this variant is going to impact, ourselves as we're back at work, and our children as we're going back to school, it's kind of going back to all those, layered mitigation strategies that we had last year, which includes masking, some social distancing, enhanced cleaning, disinfection, making sure that we have adequate ventilation. We know that the CDC and the AAP recommends masking for kids 2 and above in schools, obviously encouraging vaccination for all those age groups that are eligible. So like, as Dr. Oliver mentioned, those that are 12 and above really should be vaccinated when they're heading back to school. So I think a lot of the same rules for last year are gonna apply. Hopefully though, with a lot less remote learning, and people will be able to stay in school and just, use these layered mitigation strategies to keep everyone safe and healthy.
Thank you so much. And as we're talking about vaccination, Dr. Oliver, can you speak to the impact of COVID-19 on young people versus the potential risk of the vaccine?
Sure, absolutely. And I think it's a good point because people are always weighing the benefits versus the risk when you're making any sort of medical decision. Same thing with the vaccines. Dr. Kowalsky did a great job of explaining sort of what the impact of COVID disease is on children, right? Even though it's mild compared to adults, it's still significant. Right? I mean, 4 million cases, tens of thousands of hospitalizations, and hundreds of deaths at this point. And as Dr. Kowalsky pointed out, with Delta now, and even with the increase of infectiousness, we're going to see more cases, and that means more cases means more hospitalizations will mean more deaths. So the impact of the disease is so significant. And then you want to compare that to the potential side effects and risks of the vaccination. And so for the most part, right, adolescents, similar to adults who've gotten the vaccine, are going to have a sore arm, right? Those of you who had the vaccine, right, you're going to have a sore arm. It's going to be swollen. The most common side effects are going to be fatigue the next day, a headache, maybe fever. And these are more common after the second dose. Again, also, last a couple of days at most and easily managed with over-the-counter medications. I think the thing that people are particularly concerned about in this age group is the risk for myocarditis, and pericarditis, which is an inflammation around the heart. And this is a very, very rare, but a real risk. And I think Dr. Gelb can talk a little bit more about that after me. But so overall, though, since that is so rare, and since, in fact, if your adolescent child gets COVID, the chances of getting myocarditis from COVID disease are so much greater than they are from getting it from the infection, from the vaccine. Sorry, the benefit really does outweigh the risks here. CDC did a nice job of doing some estimates, thinking about that, and basically said, if you look at a population of 1 million, say in this case, males, age 12 to 17, and you vaccinate all of them, what you're going to do is prevent, over 5,000 cases of COVID, over 200 hospitalizations, over 71 intensive care unit admissions, and 2 deaths. You will see, out of that 1 million, 50 to 60 myocarditis cases from the vaccine. But the benefit, again, thinking about those numbers, really does outweigh the risk. So far, the cases that they've seen have been very mild related to the vaccine, but I think I'll let Dr. Gelb talk more about that. Again, one of the things Dr. Kowalsky pointed out, even though the hospitalization rate for children is pretty low compared to adults, like 0.9 to 1.9%. For me as a mom and a pediatrician, that's just too high, right? I want to avoid that outcome, and so for my patients. And so I think it's really, really important to think about that when you're making this decision.
Great. And Dr. Gelb, so Dr. Oliver touched upon the association of vaccines and myocarditis. Do you want to speak any more about any research that may be going on in that area?
Sure. So maybe I'll just start by Dr. Oliver talked about it, but let me just say a little bit more about it, if I might. So just so everybody's on the same page, when the heart muscle gets inflamed, we refer to that as myocarditis, and it typically presents or can present with the heart muscle not squeezing well, which obviously in its most extreme form is a very dangerous thing because we need our heart pumping. Then there's the possibility that not just the heart, but the lining around it, so that's called the pericardium, that gets inflamed, and that's called pericarditis. That's what Dr. Oliver referred to, and that tends to present with pain because you feel it as chest pain. And the kids that have been showing up with the combination of both the heart muscle a little inflamed and the lining inflamed, and that means they've had some pain. The good news is there are several pieces of good news. One, it appears to be quite quite rare. So overall, the rate of this reaction post-vaccine is in the realm of 5 in a million vaccines. And in the younger people, so it includes adolescents or young adults, it's about 30 out of a million. So it's really quite rare. That's first good point. It tends to show up after the second vaccination, and it tends to occur about 2 to 3 days after that vaccine. And it's particularly affecting males over females. The other piece of true good news, besides the fact that it's not frequent, is that it's been extremely mild. Although a lot of those, if you show up to my office, and I make that diagnosis, I'm going to ask, we're going to put that child in the hospital. The truth is it's been very mild. The cases have all resolved so far. There have been no deaths. So thus far, I'm not saying it couldn't change as we got more data. They've looked into about 750 cases in the US that were, felt to be vaccine-related myocarditis, and nothing bad has happened to any of them. And Dr. Oliver gave you the answer about, what happens if we don't vaccinate people. It's very clear that it's the risk for the disease still far outweigh the vaccine along these lines. In terms of the research piece, I think we very much want to know why. And I just told you it's very rare. So what's different about those few people, those few male adolescents or young men? What's different about them than everybody else who's not showing up with that? And I think understanding that might inform therapy for the future, and understanding myocarditis more broadly. Myocarditis can happen after many viruses. So I think, and we don't have great insights into it. So this is, again, an opportunity to try and learn more about it.
Thank you. Thank you both for addressing that. Now, just to talk a little bit more about risk factors. So Dr. Kowalsky, can you share with us, should children with COVID risks, such as obesity or diabetes, be more protective of themselves in any specific way?
Yeah. So we know that type 1 and type 2 diabetes and obesity, through systematic reviews and meta-analysis, there are at increased risk of more severe disease, and there's some mixed evidence of those with asthma. So I would say, for those types of underlying conditions, obviously anyone that is eligible for vaccination, we really want to encourage, that specific group to really go ahead and get vaccinated if they're 12 and above. And of course, once we get the emergency use authorization for those under 12, we would encourage those people, again, to get vaccinated, keeping with the layered mitigation strategies, mask wearing, and the other ways to protect themselves. And like I mentioned before, a lot of the underlying conditions that place people at increased risk of sort of severe progression of disease, we do have now this monoclonal antibody that can be given to children 12 and above who have mild symptoms to prevent them sort of from getting more severe illness. And again, now also has the EUA, the emergency use authorization, even for just post-exposure prophylaxis. So if they really have that high-risk contact, someone in the household, someone that they spend for a long time with, within that 6 feet, they could also qualify for the monoclonal antibody.
Thank you. Now, we've talked about the importance of vaccination. So Dr. Oliver, can you share with us thoughts on how we can improve COVID vaccination rates in adolescents?
Yeah, absolutely. And we still have some room for improvement there. And it's certainly more important now that Delta is on the scene and everyone's heading back to school. I think when you think for any vaccine, and then COVID in particular, you can think about a couple different ways to improve uptake. And one, you've got access to the vaccine, you've got vaccine confidence or vaccine hesitancy. And through all of this, you want to really think about equity, throughout all of those. And so when you think about access, is the vaccine available in enough places, and enough places where parents can and want to take their adolescents for the vaccine? And so I think we're doing a good job of this in terms of having sites throughout, in particular in New York, throughout the city. I think there was room for improvement to trying to get the vaccine into pediatricians' offices. We survey parents. That is the number one place where they want to get their children, their adolescents vaccinated. They have a relationship for the most part with that physician, that family medicine doctor, pediatrician who can answer those questions and feel comfortable, are used to getting vaccines there. So that's an area we can look into. In particular, you want to think about making sure that's happening for populations who have been marginalized and who are more at risk for COVID disease and whose vaccination rates have been lower. So particularly in our Black communities, we really want to make sure to increase access there above and beyond what might be available in other communities. And then the other to tie into that is thinking about vaccine confidence or vaccine hesitancy, how the feelings that people are going to have about weighing the benefits and risks of the vaccine. And I think thinking about, addressing people's concerns, addressing patients' concerns, respectfully understanding that everybody's scared right now. Right? People are scared of Delta, people are scared of COVID, people are, some people are still scared of the vaccine. All of this is reasonable. We want to find a place in a conversation. People can have that conversation with, either providers that they trust, community members that they trust, trusted leaders in the community. One of the things that, Mount Sinai is a part of, there's large NIH grants out there that have been given to New York City, and Mount Sinai is part of a team called the SEAL team, and looking at this and really working with community-based organizations and in neighborhoods that were severely impacted by COVID, and have been marginalized. And so really working with community members and community leaders in those organizations and the people there to say, how can we increase access to the vaccine? How can we be having thoughtful conversations, addressing concerns? And so we'll need to do the same thing with adolescents. And then thinking, again, about access, making sure that, as school opens, the New York City Department of Health is looking into ways to increase vaccination at the school. Parents are going to be bringing their kids to school, their adolescents to school through school-based health centers. Mount Sinai has a number of school-based health centers. And so really looking at that as other ways to increase access.
Thank you. That's such an important topic. And it's one of our sort of last questions for this particular portion of the webinar. Dr. Gelb, can you clarify some of the conflicting information we're hearing about children and the transmission of COVID to others?
Sure, I tried to. So I think early in the experience with the pandemic, some misinformation really or misunderstanding arose, because what happened was when everything shut down and schools were amongst the first places to shut down, kids were sort of sequestered. And so we didn't see much evidence for transmission. So this idea arose that kids couldn't pass along COVID. But I think now, we're much further into this, we're wiser. We know that's not the case. Children of all ages can certainly pass along the virus. We've seen over the summer in camps, for instance, kids passing it, teenagers more so, but certainly we see that. What may be the case, though, is that the ability to pass the virus on to others is probably higher in teenagers than it is in younger children. But the fact still remains that young children are capable of passing the virus along. So that's why it's important in most experts' opinion that the mitigation strategies need to be used as schools open, because we do know the risks are there, and until they can be vaccinated, there's no way to completely shut it down if you don't take any of those measures. And lastly, we do know that kids tend to be asymptomatic carriers quite frequently, so that's also part of the risk. Is you have people who don't know they're having it and they're exposing others. That happens in adults too, clearly, but seems to be a bit more common in the younger kids. So the bottom line is, for sure, kids can pass it along. And we can't just assume that they can't. That you're still hearing that. Sadly, some parts of the country, some politicians are saying we don't need to have the kids masked or distanced or whatever because they won't. But that's incorrect information.
Thank you. Thank you for really clarifying that important point. At this time, we'll take audience questions. Please use the Q&A feature to submit your questions, and we'll try to get to as many as we can. As I'm sure you have many questions, and if we don't get to them, we will definitely make note and be in touch with an answer after the webinar takes place. And before we do that, I'd really like to take the time to introduce Dr. Lisa Satlin. Dr. Satlin is the Herbert H. Lehman Professor of Pediatrics and Chair of the Jack and Lucy Clark Department of Pediatrics and the Pediatrician-in-Chief of the Mount Sinai Kravis Children's Hospital. Hello.
Hello.
Thank you for joining us. So so we are getting some questions from the audience, and anyone can answer this question. But the first question is, if children are in close proximity outside, should they be masked? And I don't know if Dr. Kowalsky, if you'd like to.
Yeah, I can comment on this one. So, I think as a school year last year was ending and we were going to the summer, there was sort of that like relaxation of like, oh, we don't really need to wear masks outdoors with the fresh air. And, our numbers were much lower. And so I do think in general, the risk of transmitting COVID outside is significantly lower than when you're indoors in close proximity in maybe a room that's poorly ventilated for a long period of time. So I don't want to say that you don't have to wear a mask outdoors. I think every situation is probably different, but I think for kids kind of like running around and passing here and there, without really having that close, intimate contact for a long time in an outdoor setting is probably pretty low risk. And therefore, you could consider foregoing the mask in certain types of outdoor situations.
Thank you. There's another question. Is there any data regarding reinfection in children?
I don't have an answer to that one, Dr. Kowalsky or Gelb. I haven't seen data on that yet.
I don't know specifically. I mean, I think we know in general that probably, look, I think with the Delta variant on the scene, everything is new and we're going to be learning a lot over the next few months, especially as, schools are opening and everyone's gathering back together in close proximity. But I think in general, in terms of reinfection, it's really thought that reinfection is unlikely, at least in the 90 days after the initial infection, probably even up to like 6 months. And that probably, applies to children as well. I think now, with maybe some waning immunity over time and, the Delta variant being more infectious and more transmissible, we may start seeing more, reinfections over time.
Thank you. So this question is for maybe Dr. Oliver, if you wouldn't mind answering this one first. So can you tell us, how is this vaccine different from the others my children have received? Why should I feel totally confident to give this to my 3-year-old?
All right. So first of all, not for 3-year-olds yet. So we don't have to feel confident yet. But but hopefully we're gonna get there soon. So basically, all vaccines work by stimulating the immune system to make antibodies. So to the virus or the bacteria, so that if you do encounter that virus or bacteria in real life, your body's ready to go and fight that infection. The thing that's different about these mRNA or messenger RNA vaccines, which is the way that Moderna and Pfizer work, is that rather than giving the protein from the virus that your body then reacts to, or giving it's the whole virus itself in a deactivated form, what we're giving instead is the instructions to make that protein. And so it's just that sort of delivery mechanism. Everything that happens afterwards, the immune response and the antibody development, is basically the same. And so that's sort of, I think, why a lot of us, and there's a question up there about, potential for really long-term side effects from in particular the mRNA vaccines. I think those of us who are in this field, and certainly the experts at CDC as well, feel really comfortable looking at shorter periods in terms of side effects. What you generally would see a side effect as a result from a vaccination is going to be maybe 6, maybe 8 weeks after the vaccine. Don't expect any long-term side effects. And somebody asked in particular about puberty or fertility, right? So really don't have a clear reason why that would happen. And so don't expect those types of long-term side effects. The short-term side effects, a rare one would appear 6 to 8 weeks, and we can feel confident about this because of the trials that are getting conducted, that will eventually be conducted in this age group. And then really importantly, what they call licensure monitoring. And so even after the vaccine is given emergency use authorization or fully approved, we have systems in place to really track everyone and track any adverse events or side effects. And that's why we got data so quickly on the myocarditis link between the vaccines. And, so something, even though incredibly, it's so rare, but we were able to pick it up really quickly, I have to say. And so those systems give me confidence in terms of being able to recommend this vaccine. And they're going to be in place for 3-year-olds as well when that vaccine becomes available for them.
Great. Thank you so much. And there's a somewhat related question to something that you asked earlier about access in terms of vaccination. Why is it that the majority of regular PCPs for adults don't have the vaccine to give to their patients?
Yeah, no, it's a great question. Yes, ideally, we want the vaccine in all offices. The problem has been, one with the storage and handling of these particular vaccines. So they had to be kept in super freezers. That has relaxed a little bit, but it's still challenging in terms of the amount of vaccine that can be distributed at any one time. So there's sort of large bundles of vaccine that some practices wouldn't necessarily be able to use up in time. And there were concerns about wastage. So I think as we think about this COVID not being a sprint, but a marathon and probably sticking with us, we're going to develop, and practices will be able to develop additional strategies so that we can start vaccinating more and more, including adults in practices. It will be, one of the, more of a routine vaccine, if you will. The other challenge is being able to, manage that volume and maintain the appropriate distancing that we're doing to keep patients safe when they come into the offices. So all of it's logistically it's challenging, I think doable. And I think we'll start to see the vaccine more and more in offices. Certainly the health department has been pushing that as well.
Thank you. So Dr. Gelb, this is a question from a participant. So if kids mask all day at school, but eat lunch in their classroom indoors, does that defeat the purpose of masking?
Absolutely not is the first part of the question. I mean, part of this has to do with exposure, and part of the equation for exposure is time. So clearly those school points in time, and lunch is the big one, where you have to take down your mask, is going to increase the time when there's more virus floating around because mouths are open. Schools are generally very much aware of that, and there are a number of strategies that they can use to try and mitigate that problem. Perhaps not, in New York in January, but going outside is an old trick. And Dr. Kowalsky talked about the benefits of being in fresh air and the airflow of that. That not being possible, which it generally isn't, and most schools won't be doing that, of course, there are other things they can do. So one is to try and distance the kids more during lunchtime. And part of that, some schools will be trying, is extending lunch hours so that the density, the number of kids in the whatever space they're having the lunch in, is dropped. Another thing which happens behind the scenes, but I can pretty much assure you that your schools are thinking about, is doing steps that increase and improve airflow. Because the better the airflow is, the more exchanges there are per hour of the air, the lower the virus will be hanging around. And then the third thing that they can do, and I'm not saying all schools will do this, but there are strategies that are being discussed about this. I don't know how many people on the line were campers, but I remember vividly, color war, which I now realize was just a way to keep us behaving well as camp came to an end. And one of the contests was always which color, I was usually on the gray team, which color could be the quietest during meals. So, the less kids are yelling and screaming, the less virus is being propelled out in the air. And so schools will be trying strategies to keeping little kids from yelling and screaming when they don't have their masks on. And it's going to take some creativity. But those are the kinds of things that can be done to try and minimize the risk of transmitting during lunchtime.
Great. And
I want the results of those studies to try at home because I could use that.
Great. And in kind of a related question that was asked for Dr. Kowalsky. So do you think cloth masks are sufficient for unvaccinated children in school without social distancing? Would you be okay with surgical masks or feel like you need to do N95 style masks?
Yeah, so I mean, just in general, the N95, respirators really are supposed to be reserved for healthcare workers, and they require actually like a fit testing to make sure that it fits your face properly. So really, that level of masking, isn't really necessary for the general population. I think the best masks for kids are the masks that your kid is going to wear, right? So like it's going to be on their face all day. They're going to be touching and wanting to pull it off. If it's not comfortable, if it's bothersome, they're not going to want to wear it. So you probably have to try out some different masks to see, which is a favorite, which is a winner. In general, the mask should be like 2 to 3 layers deep. So that will help like filter out more of the virus particle from them expelling it, or also from it getting in, to their nose and mouth. It should fit appropriately over the nose, over the mouth, go down by the chin. Shouldn't be like gaping and loose. And so really, like I said, I think, either a cloth mask, a surgical mask, whichever mask your kid is going to be able to wear, throughout the day. Again, the AAP does recommend it for those children that are 2 and above. So I think you'll have, there's a lot of choices out there now with different prints, different colors, styles. So.
Thank you. So another question that's come in from our audience. Are there theoretical long-term risks for prepubertal children in receiving the vaccine? Is that something families should be worried about?
No. So is the short answer. I think it's natural to worry about puberty and in general. I think that's, but in particular for the vaccine, there's not even a theoretical pathway that I can imagine. And Dr. Kowalsky, Gelb, you can jump in here too, for why an immune response to a vaccine would have an effect on puberty. So understand that concern, right, as a parent. But I can let that one, I can take that one off of your shoulders. I often say this, like, I'm a worrier, right? I worry about my kids. I worry about my patients. It's just sort of my natural sense. And that is just not on the list of things that keeps me up at night, if that can help.
Great. Thank you. So as we think about, Dr. Kowalsky, some of our youngest children, and this is from the director of a nursery school, what are the best precautions to protect 2 to 5-year-olds until they're able to get vaccinated? They actually moved their school program completely outdoors in response to the pandemic. And teachers and children wore a mask. Any other kind of insights for the youngest?
Well, I'm a mom of a 3-year-old who went to school last year, so I have a little bit of personal insight. But yeah, I mean, I think in general, again, like really encouraging those, 2 and above who are able to wear their masks. That's really going to help prevent the spread of the coronavirus, in addition to a lot of other respiratory viruses that normally circulate. Obviously, good hand washing, good cleaning and disinfection. Kids are kids, they want to play, they're on top of each other. It's sort of like the normal socialization. I think having the other family members of the household that are eligible to be vaccinated to sort of help cocoon the children and prevent them from getting sick is always, beneficial. Having the children, having the teachers in the school vaccinated and wearing masks, those are all some, ways that you can help. Opening the windows, as Dr. Gelb touched on a lot of it about the ventilation being a really key part and allowing fresh air to come in. So I think there are safe ways for those in the sort of early childhood years to attend school.
Great. So this is, we were talking a little bit about some of the long haulers. And our participant wants to know, is there a clinic for long hauler adolescents as well as long hauler adults? I know that we spoke to some of the observation that's being done regarding this area. Dr. Gelb, can you speak to that, or Dr. Kowalsky?
Maybe Dr. Satlin wants to try that one. You're muted.
Yeah, thank you. Thanks, Bruce. I had to unmute. So there is a clinic for adults who are considered to be long haulers. We do not have that for children as yet, per se, because we've really not defined, what a long hauler is in pediatrics. However, children who have been hospitalized with COVID or MIS-C are followed up by some of our subspecialists here at Sinai in a sort of multidisciplinary program that includes follow-up by rheumatology, by cardiology, and others. The number of these children that we're following is very, very small. But, should there be a need, they can certainly be followed by the team at Sinai. I think, Shanna, you're involved in that as well.
Yeah, I would say mostly the patients that we sort of follow in the multidisciplinary team are the ones that have, been hospitalized for the MASC and have recovered. And it seems like so far, fortunately, from my experience, we haven't seen many, children that have really had persistent sort of, long symptoms over a long duration.
Great. So this is another important question. So do we need to wait between giving the flu vaccine and COVID vaccine, not co-administration, but rather can children get both vaccines within a 14-day span or less?
Yes, you can get the vaccine within a 14-day span or less. You could do them on the same day. You could do them the next day. You could do them 3 days later. All of that is okay. Approved by ACIP and the American Academy of Pediatrics. I think we should have flu vaccines soon, so I'd recommend everybody getting it for themselves and their children as soon as it's available. Do it earlier than you normally would, just so you can get that visit away. Make sure you're going to have that extra protection for yourself and for your family against flu. But I would not keep that from getting the COVID vaccine.
And this is another very just real life question from one of our participants. If children are in proximity to vaccinated grandparents with increased risk factors, would being outside with masks be sufficient, or should one also make sure to keep 6 feet apart? Does that make sense in terms of just a mask, or you also do the social distancing?
No, it makes sense. I mean, Dr. Kowalsky, you can weigh in on this too. I mean, I think you said before, it's a layered strategy. So there's different things that you can do. You can be outside, it's going to minimize your risk. Being further away is going to minimize your risk. Masking is going to be minimize risk. There's not a randomized control study that evaluated all of these different strategies with grandma and grandpa who have risk factors, right? And so it's sort of our best, if you want the most protection, then you're going to do all of those 3 things, right? It depends on sort of what how comfortable you are, I think, a little bit too, and what level of protection you want to give. So the most protection is doing all those 3 things. You drop each one and you get a little bit of less protection each time, depending on who's involved. That can be reasonable. Dr. Kowalsky, I don't know what are your feelings on that?
Yeah, no, I couldn't have said it better. Yeah, I mean, I think it's a balance, right? It's been a year and a half. We've stayed away from grandparents and elderly people, and it seems like, I think we were a little bit hopeful that maybe the pandemic was going to be going away, like as more people were getting vaccinated, and we saw like really the numbers declining, as we were heading into the summer, and now we have the Delta variant. It seems like things are now going the other direction. So like you said, this is not a sprint, it's a marathon. I think we're going to be dealing with this for a long time, and we have to sort of find a balanced, safe way to interact with people where it's meaningful in our lives, and sort of a risk benefit. And try to be safe, but also be able to have those meaningful interactions with loved ones and friends.
I mean, if it helps, I had my kids with my their great aunt who was 91 last week, and it was incredibly hot, but we were outside. They weren't masked, but they were, a little bit further away. We all had a really nice time. We had to get great aunt back inside before I think she had heat stroke. So there was that risk benefit there as well. But that's sort of that's where I'm at the moment. That may change as Delta changes too, but that's sort of what we were comfortable with.
This is another question in terms of, living our lives. How do you feel about airplane travel for non-vaccinated children, specifically some of the longer flights?
Yeah, I mean, I'm also like a mom. I have young kids. We've been home for a year and a half thinking about going to visit family or, finally doing something fun. Was thinking about when's the trip going to be? Probably should have done it, 6 weeks ago. So I felt like at some point, with the airplanes, they seem like they're safe. They have good ventilation with the masks on. To be honest, I'm a little bit more worried with Delta now kind of circulating, being more transmissible, being more infectious. I think in general, people have relaxed a lot. This pandemic is carrying on and people sort of want to get back to their lives. And there's a lot of people that aren't masking. And so feeling, confident in airports and in the airplane, and also depending on the destination where you're going, if you're going somewhere where there's really a high level of coronavirus circulating, thinking about the destination as well. So I feel like, again, everything is a risk benefit, but travel right now, again, is starting to make me a little bit more concerned than maybe it had been earlier in the summertime.
Thank you. There is another very relevant question around additional shots or boosters in the immunocompromised. Would anyone like to speak to that?
So I can go. So recently, there has been a recommendation for people who are immunocompromised to get this additional dose. And basically the idea is, if you were immunocompromised at the time of your initial vaccine series, you didn't mount the same, immune response as somebody else would have to provide a certain level of protection we would expect or want from the vaccine. And so an additional dose to complete essentially your initial series has been recommended for specific groups, who have either immunocompromising conditions or on medications that compromise the immune system. So that has been recommended now in the US with the two mRNA vaccines, so Pfizer and Moderna. For Johnson & Johnson, there's not a recommendation at this point because they don't have the data yet to do that. And so they're waiting for that data for that group. I mean, I think if that applies to you, I definitely have, you can have a conversation in terms of which immunocompromising conditions, have a conversation with your doctor about that.
Thank you. I'm just looking at some of the newer questions that have come in. So what do you think of these cases of RSV in children in the South this summer?
I mean, I can sort of take that one. We're seeing RSV here also, in New York. I think RSV in general is kind of circulating around the country. In a state like Florida, RSV sort of goes throughout the year. In New York, it's typically a virus that we see from October, through the end of March, but we keep seeing it, month to month as it's going on. And sort of the season now is kind of going the entire year. And I think, mostly what's happening is kids were masked. A lot of kids were not in school. A lot of kids missed out on getting RSV when they typically would have in the first, year or two of life. And so now you have everyone that's really young, like small babies under 6 months, under a year, that are getting RSV, plus all the kids that are 3 years old that never got RSV because they've either been home or been, masking and doing all those mitigation strategies. So I think just the numbers in general of RSV are really up throughout the country. We're definitely seeing it here. To be honest, we're seeing more RSV, I think, than we are coronavirus, especially in terms of requiring inpatient hospitalization.
Well, thank you. This has been really informative. And so, as I mentioned earlier, if we weren't able to get to your question in the chat live, we will follow up with that question. But I would just like to ask each of our panelists, what are the most important takeaways that our audience should know about children, should know about COVID and the vaccine?
I guess I can go first. Just in general, I think in terms of, children and COVID, again, most children fare very well. They usually have mild illness. Most do not require hospitalization. We do have ways to treat them should they require an escalated level of care. I would really recommend, masking for children 2 and above, as is recommended by the American Academy of Pediatrics. I'm really excited that, this year, kids are going to be able to go back to in-person learning in school setting. I think that's going to be really huge for them. I really feel like they missed out a lot in the past year and a half. So I think really by adhering to the different layered mitigation strategies, it will allow our kids to remain in school safely, which is really like of utmost importance for them, both medically, developmentally, socially. There's so many reasons why kids should be in school. And I would just encourage families to strongly consider vaccinating their children that are 12 and above, and as well as, encouraging all adults to get vaccinated, because that's really probably going to be the only way, out of this pandemic.
Yeah, I echo everything Dr. Kowalsky said. I think I was talking to somebody recently about Delta and saying I went through all 5 stages of grief with this, right? I was in denial, then I was in anger, and I've sort of come to acceptance, recognizing that it's not all over, and we're gonna be digging in for a little while. But we have, as Dr. Kowalsky, all these strategies, right? And so I think number one, the vaccine. I think if you just tuned in, the benefits outweigh the risks of the vaccine, and that's going to be our best way out. But we do have additional strategies, and that we're going to have to stick with for a little while longer in terms of the masking where appropriate, especially indoors, especially in school for children. And I think that, remembering all of that we have these additional strategies, we have the additional therapies that are available now, hoping to take away some of that anxiety, both as somebody mentioned for their adolescent, because it is stressful, and for the parents as well. And so just remembering that these things work, and they're going to continue hopefully to work and to get us through this.
So I'll just pick up on that. I think a lot of people are obviously bumming out. We thought this would be such a free summer, and it has not turned out that way. And it's easy to fall into a thinking that this is going to be awful forever. My kids are going to be wearing masks for the rest of their lives, that sort of way of thinking. I think while none of us knows precisely what lies ahead, I think we can say what's likely to happen. Just to give some context, I alluded earlier in this webinar to the 1918 flu. Just so everyone knows, that flu is still circulating amongst us. It is occasionally part of our annual flu, and we've just come to live with it. We have strategies, we use vaccinations. It is not perceived, it is not this overwhelming thing. I think that's likely to happen with this virus as well, the coronavirus. I think it may be what we call endemic. It may be that there is an annual coronavirus that we'll have to deal with, but we'll be prepared to do it. And the second point that's related is, if the history of what we know, and there's a really cool piece in the New Yorker this week, if people want to look at that. But when these viruses, same with bacteria, they evolve, they change. That's why we now have Delta when we had Classic, and Delta's worse. But actually, the capacity of these things to get worse is not infinite. And what tends to happen is we select out the bad ones, and that tends to happen early-ish in the experience with a new pathogen. So I'm not going to say that there won't be something that's, double worse of Delta. I suppose that's possible. But just know that this virus cannot infinitely keep changing and making life miserable. At some point, it plateaus. That's what we've seen with other pathogens, and it's very likely with this too. So, that's different than saying it's going to end this fall or by this time next year. I think we're all hopeful for that, but it will not go on indefinitely.
Well, thank you all. This has been such a timely and relevant session. And thank you again, Drs. Gelb, Kowalsky, and Oliver, for providing so much insight regarding COVID and the best way to protect our families and children. Thanks to everyone in the audience for attending and providing such thoughtful questions that led to this rich discussion. And as a primary care pediatrician, I'd like to also reinforce the importance of keeping regularly scheduled checkups and vaccine appointments. We know that in addition to the health concerns with COVID, many families have had to deal with economic, psychosocial, and educational challenges, just to name a few. And during our routine checkups, we also address important areas such as development, behavioral and mental health, help maintaining a healthy weight, and we provide age-appropriate screenings as well as immunizations to protect against other preventable illnesses. Also know that as a Mount Sinai Health System team, we work together so that we can provide care in a safe manner, which may include telemedicine visits as appropriate, as well as in-person visits that are done in a way to mitigate risk or decrease risk. And we also work with our entire team of social workers to connect families with additional services that are needed. So thanks again for everyone's participation. And lastly, we'll have a special QR code or flow code that will be on the screen. Just point your smartphone camera at it, and it will take you to a web page where you can support the work that's taking place. So thanks again, everybody, for your participation.